Hello guys, I am back with another video on pharmacology today. I'm sorry guys, I am very late because there has been many things going on in my life and yeah. So today we are going to discuss the non-steroidal anti-inflammatory drugs. So let us begin. Now, in order to understand this drugs, we should first understand what is inflammation. So inflammation is a defensive process that the living body initiates against local tissue damage. Okay. And there are five cardinal signs of the inflammation. They are the pain, temperature, edema, hyperemia, and the functionalism, that is the dysfunction. Okay. So wherever there is inflammation, we can see we can observe pain. There is increase in temperature. There is edema. There is a hyperemia. That is the yeah, the like the area which has gone inflammation, it becomes red in color. Okay. And loss of function, like we can't use that particular thing. Now let us discuss briefly about the uses of this NSAIDs. So these are very useful in the controlling inflammatory pain, such as that seen in the arthritis, rheumatism, and gout. And these are also helpful in the treatment of headaches, dental pain, and various musculoskeletal disorders. Now let us talk about the mechanism of action. So guys, these drugs, they inhibit the COX-1 and 2 enzymes. Now you might be wondering, what are these COX-1 and COX-2 enzymes? So actually there is a pathway called the arachidonic acid pathway. Okay. Like when the stimulus comes from outside, the membrane phospholipids, they bifurcate and produce this arachidonic acid. Okay. And why the enzyme called the phospholipase A2. Okay. And this arachidonic acid acts as a precursor for the leukotrienes or prostaglandins. Okay. Now, one of the way by which this arachidonic acid may get transformed into this prostaglandin is via the COX-1 and COX-2, and another way is via the lipooxygenase, which will transform it into leukotrienes. Okay, so these NSAIDs, they inhibit the COX-1 and 2. Okay, actually there are two types of inhibitors of this COX-1. First is the non-selective, which will inhibit both the COX-1 and COX-2, and second is the selective COX-2 inhibitors. Okay, so the term non-steroidal differentiates them from steroid drugs that mediate the anti-inflammatory effects through activation of glucocorticoid receptor. Example is the cortisol. Okay. Yeah. Now, as I have discussed in my previous slide, the cyclooxygenase enzyme is the enzyme that converts arachidonic acid into prostaglandins, important mediators of inflammation. Now, guys, this prostaglandins are very important for the vasodilatory effects, and also for the chemotaxis of all the inflammatory cells. Okay, so these are the very important mediators of the inflammation. Okay, so by blocking these by blocking these enzymes, which are required for the production of prostaglandins, these drugs are very helpful in the pain management. Okay. Now, arachidonic acid is the primary precursor of prostaglandins and related compounds. Okay, and this acid is a component of phospholipids of the cell membrane. Now, diving deep into the cyclooxygenases. So these are the enzymes which are localized on the endoplasmic reticulum and are responsible for the formation of from arachidonic acid of a group of local hormones comprising of the prostaglandins, prostacyclins, and thromboxans. Okay, and NSAIDs except aspirin. Okay, are reversible inhibitors of COX enzymes. Okay. Now, thus all the NSAIDs act by inhibiting the synthesis of a prostaglandins. Inhibition of cyclooxygenase enzymes lead to decreased prostaglandin synthesis with both beneficial and unwanted effects. Now, guys, these are the drugs which are used in the treatment of the pain. It may be somatic or visceral, but usually we use these drugs for the somatic pain, for the treatment of the somatic pain. Okay, so there are two types, uh, as I have discussed. Non-selective drugs, which inhibit the both COX-1 and COX-2 enzymes. These are aspirin, diclofenac, ibuprofen, indomethacin, ketoprofen, piroxicam or phenoxycam, naproxen, and the ketorolac. Okay, so you need to remember all these drugs. Okay, and the selective COX inhibitors they are denoted by the COX-CYPs, like celecoxib, meloxicam, uh, rofecoxib, valdecoxib, and nimesulide. Now coming to the pharmacological effects of the NSAIDs. So, if you know the mechanism of action of these drugs, you should be able to guess um, the effects of this NSAIDs. So first is the anti-inflammation effect by the inhibition of the synthesis of the prostaglandins. Okay. Second is the antibiotic effect by inhibiting the fever-producing substances, endogenous fever-producing agents. Third is the analgesic effect by reducing the the pain in the injured tissue. And fourth is the anti-platelet action. For example, aspirin is a anti-platelet drug. Now coming to the clinical uses of these drugs. So they are used for the treatment of mild to moderate pain, especially the pain of musculoskeletal inflammation. For example, arthritis, rheumatoid arthritis, seronegative spondylo uh, arthropathies, example psoriatic arthritis and arthritis associated with the inflammatory bowel disease. Osteoarthritis, it is a very common disease of elderly. Localized musculoskeletal syndromes like sprains and strains, low back pain. Gout, indomethacin is popular for gout, except tolmetin, which happens to be ineffective in gout, and bacterial disease, spondyloarthropathies. So, guys, this ketorolac is a notable as a drug used mainly for as a systemic analgesic, not as an anti-inflammatory drug, and for the treatment of ordinary pain, a dose of approximately 500 milligrams of aspirin is required. Oral ibuprofen is often prescribed in low doses, at which it has a analgesic but not anti-inflammatory efficacy. Dysmenorrhea, non-selective NSAIDs reduce polyp formation in patients with a primary familial adenomatous polyposis. Now, the long-term use of NSAIDs reduce the risk of colon cancer. Several NSAIDs, including the aspirin, appear to reduce the incidence of colon cancer when taken chronically. And cardiovascular application are the aspirin. Aspirin, it is well known for its anti-platelet action. Okay, so low doses are used prophylactically, that is dose of 81 to 325 milligram once daily to reduce the risk of recurring transient ischemic attack and stroke, reduce the risk of death in those having acute myocardial infarction, reduce the risk of sudden death in patients with chronic stable angina pectoris, and decrease thrombosis in patients undergoing certain vascularization procedures after coronary artery bypass grafting. Now, this aspirin is now not used as an anti-inflammatory medication. It is now used as an antiplatelet drug. Okay, at low doses, 100 to 200 milligram daily, aspirin usually inhibits the platelet COX-1 mediated thromboxane synthesis of in platelets, so that the antiplatelet action of the aspirin lasts up to 8 to 10 days, which is the life of platelet. Patent ductus arteriosus in premature infants. It is actually a shunt between the pulmonary artery and the aorta in fetus, and this needs to be closed in order to survive the fetus. So there are two drugs which are available to decrease the shunt be, be, between these arteries and the aorta. These are the ibuprofen and the indomethacin. Ibuprofen can be given orally as well as intravenously, but the indomethacin i- it is only given intravenously. In the last slide, I have discussed the comparison between the non-opioids and the opioid. Uh, fuck, I can't pronounce this word, guys. Analgesics, yeah, analgesics. Okay, so this NSAIDs, they are the weaker analgesics, and this opioid they are the stronger analgesics. Okay, and this NSAIDs they act peripherally, and this opioid they act centrally. This NSAIDs they do not depress the CNS, and in and opioids they depress CNS. Okay, and there is no abuse potential for the NSAIDs, whereas in opioid there is. Okay, and there is no physical dependence on the NSAIDs, and in contrast, opioids have physical dependence and also mental dependence. Okay, guys, so that's it for today, guys, and thank you for watching. And yeah, remember to subscribe. ठीक है.